So we're on week 6 now. We are in the middle of, pediatric nursing. This week we're doing reviews. I was gonna do mine on Thursday, but I changed it to Friday. Found out at a doctor's appointment my infusion, and I couldn't change it. Um, I had changed it on the announcements to let you know. Um, the following week we're gonna have exam 2, then it's HESI, and it's going to go really, really quick. So anybody who wants to meet with me before, let me know. If you need some more help with math, let me know. Always know that you do have recordings on my YouTube site. If you want to look at dosage calc, there's some shorter ones, some longer ones. And if you need any of the worksheets that go with them, let me know because I
Miss
can send them also to you.
Miss Bogart, how many exams do we have? Three, no?
We have 3 exams and a HESI. So, we're on week 6. So week 7 is exam 2. Week 10 is exam 3.
And then Hesse. Okay.
And then week 11 is HESI. And then
Okay,
it's
you
three
scared me because I thought it was
abbreviations.
like we only have one exam more and then Hesse. I was like, wait, what?
Well, we're getting ready for 2, and then it's, onward. I think that exam 2 is the one if you can beef up a score going into exam 3. Now you have all these projects due, community stuff due, stuff for me. So to get a good exam 2 score does give you cushion. And I think that's what I was trying to say, because I know what your schedules are right now. So this week, what are we going to do? We're going to be going over hematology, immunology, and cancer. I've got the PowerPoint, of course, and I do have a Kahoots to follow. Remember your CJ Sims and your NCLEX questions. Anybody, and there's a couple, not many, but if you see a 0 on one of those assignments, go inside of it and look at the comments. Maybe you didn't submit it correct, or I couldn't see something or something. And I do always give you till Sunday, to correct it and get it back to me. So just go and look at those things so that you can get, the points that you deserve for those. Okay. So let's go ahead and start with all about blood. Blood tells us a lot about everything. Talks about, our hemoglobin, it talks about our immune system, and it also talks about our bleeding and how we bleed or not. Now, when we want to go and investigate, any sort of problems with hematology, immunology, I mean, even bleeding dysfunction, I mean, you always start out with a basic CBC. CBC is going to talk about your white blood cells. Going to say, well, oh, those frequent infections, that's why the white blood cell count is elevated, or maybe it's too low. Looking at it, looking at hemoglobin, hematocrit, and it's too low. Well, then looking at the cells, why is it too low? Figuring out what type of anemia is, and then asking this child, what's going on? Most of all, when you have a child who has low hemoglobin hematocrit, these children, it gets to the point where they're very tired and they can't move, and they're just not the normal cells. And that usually, says the parent not acting right. So let's figure out what's going on. Okay. And then, of course, with the hematology, there's always those platelets there, and we forget about them, but they're a very big component on blood clotting. So, red blood cell disorders, anemia, the most common of all, right? And it's all just basically a decrease in red blood cells, which is your hemoglobin and your hematocrit. Well, what does a red blood cell do? It carries oxygen and it carries iron, food to the cells. So if you don't have enough of them, guess what? Your body is not getting oxygen and it's not getting that iron, the food that it needs. So there's no fuel in the tank. It doesn't want to move. So that's why the red blood cells are so important. Now, red blood cell disorders can be caused by many things. We're going to go into them. We're going to look at size, shape, and whatnot. And then know that they consider a hemoglobin less than 10. And that's usually with children that are after the toddler stage, because we know toddlers are always in that little bit of anemic stage because how many toddlers like green leafy vegetables and stuff high in iron, right? And they're that finicky eater. So, but after that, about 10, um, probably is your break off. So you get this child comes in, mom saying they just don't have the energy, they're tired out easily, they're taking naps when they never did. So you're suspecting maybe it could be anemia. So you listen to the heart. Now, with a normal blood, it's full up. So it swishes through the heart. And you just hear normal, it just goes through, but you don't hear noise. But when the cells are lessened, there's still all that fluid that holds those vessels open, and the cells bounce off, and you hear, and it sort of swishes in there and you can actually hear. So, I mean, other things you might hear is some tachycardia, heart's trying to beat more, of course, and the color, whatever. But when you hear that swishing, that's your definitive yes, this child is anemic. So, let's be concerned now. Yeah, you might see long-term effects of anemia can cause cyanosis and growth retardation, but hopefully we don't wait too long, right? Now, there are types of anemia, like I said. We know that there's iron deficient anemia. Oh, we've all heard of that. That's your nutritional. But there's other nutritions that we could be depleted from or that our body doesn't like. Folate, B12, the intrinsic factor, right? B12. And then there's bone marrow failure. This is when you get leukemia, right? Aplastic anemia, and I'll go into that one a little bit later. And then some overwhelming infections can cause that. And then you can't rule out low hemoglobin hematocrit because of blood loss. A lot of times, some of these bleeding coagulopathy problems are found out because children are coming in the emergency room and doctors' offices with repeated nosebleeds, epistaxis. And after the normal treatment, and they're still complaining, that's when they're going to take blood and look at bleeding coagulopathies, the PT, the PTT, SCBC, of course, looking at platelets and seeing why is this child's nose continuing to bleed, and then they rule out stuff, and I'll go into what that is in a second. And then we have increased red blood cell destruction. So we have red blood cells, they are born, they're made, but they're dying extremely quick. Sickle cell anemia. Many of you have heard of that one already. And then that's the African American usually. And then that thalassemia. Now, thalassemia is Mediterranean area people. So those one are sort of specific to some cultures. And then there's some other ones in there. And then we have something that can happen that something comes into the body and destroys cells, whether it's cancer, which is you're getting chemotherapy, could be drugs, some toxic something, and that will kill cells too. So that is in your book. You can go back to refer to that also. So you have a child come in and you're suspecting some sort of anemia, some sort of something's going on. Well, of course, history, physical, tired, more easier than usual. Then CBC, let's just look at are we fighting infection? How's our hemoglobin? And let's look at the bleeding by the platelets. Now, the other thing is many times you get a child who's in with low hemoglobin, low hematocrit, and you have to do something. Well, many times they will do transfusions, but sometimes waiting for that blood will all of a sudden start give some IV fluids, will expand the vessels just to give volume in there. But again, why is the child bleeding? Why is their red blood cells, not there? I mean, always number one, let's check for obvious. Is there occult bleeding? Let's do a stool for occult blood. That's obvious. Number one, they do. Then that's negative. So then look at racial ethnic backgrounds. Are they African American? Are they from the Mediterranean area? So let's look at that culture thing. Once we figure out, well, what we're looking at, this child needs, because of the hemoglobin hematocrit, some further laboratory tests. We're always going to prepare the child and family. We're not just going to say, hey, sit down. And, we've learned in this course that it's easier to sit with the child a little bit, play a little bit, gain some confidence, take that time because they're going to get that blood test and they're not going to be upset. And instead of a kid crying, I don't like kids crying. Furthermore, you have a kid who's already anemic, who doesn't have oxygen, and they're crying. That's not a good thing because they don't have any energy. Now, iron deficient anemia. We've heard of this. This is because we're not eating enough dietary iron. I mean, there are many picky eaters, as I've mentioned, of course, those toddlers. Um, but there are, even when we get older, the adolescents. School age still have to eat what mom wants, but then at adolescence again, they're going to eat what they want. And remember, they go through that growth spurt again, that 20 to 25% of their height, right, is in that pre-adolescent, adolescent stage. So with all of that, that's usually when they become um, iron deficient anemia. They say milk babies. What is a milk baby? Well, uh, there was a time where when you didn't have breast milk, they just gave whole milk from the cow. And these babies were deficient of many things because they needed the iron and all of those things that are in iron fortified formulas. So milk babies are ones that are put on whole milk too early and they don't get the iron or whatever else they need. So up till 1 year old, they should be on iron fortified formula or breast milk. And then they can be on whole milk. So prognosis for iron deficient anemia is great. You just have to change your diet. Now, sometimes children, adolescents, adults can be really not as compliant as they should with eating. So sometimes you have to do iron supplementation. Remember, with iron in children, it's usually liquid. Do you remember what you were taught in pharmacology? They drink it through a straw and it should be on an empty stomach because it needs the gastric acid to digest it to make it workable for the body. And if you take it with orange juice, the acid in the orange juice helps it more. So before meals, empty stomach with orange juice through a straw. I've seen this one on the Hesse about this one. So I'm making sure you know what it is. Okay, sickle cell anemia. Both parents have the trait. 25% a child will have the disease. Okay, what you need to know. Now, let me try to explain sickle cell probably in a different way to you. Think about sickle cells, they're shaped like a C, like a sickle. Think about all the little vessels that bifurcate and get smaller and bifurcate. And think about these cells squeezing through that. And then all of a sudden, at a bifurcation, it gets stuck. One cell closes it open, and now other cells can't go down. That's when a sickle cell crisis occurs because the vessel's too small and that cell can't get through. So, in a crisis, this one clogs it, and all the ones behind it backs up and it swells, hitting the nerves, creating pain, creating redness, tenderness, and it creates a no blood flow going down below that area of that blockage. So it is imperative that we start blood flow and we get that cell unhooked, dilate the vessels, and get those blood cells going. And it can happen anywhere where there's a blood cell, in the brain, in the eye, in the chest, in the tummy. Usually we see it, I've seen mostly like in the chest, actually, in the ribs area. I've seen it a lot in knees and elbows. So what do you think if I've just told you this is all about little vessels and cells getting stuck? Guess what your priority for treatment for this is going to be? Get that vessel big, dilate it, bolus the fluid. Number one priority. Let's treat what happened. Now, what causes this? Well, any disease globally in pediatrics, immune compromised, sickle cell, cystic fibrosis, rheumatoid arthritis, anything that's immunosuppressed, we will tell them you have a temperature of 100.5 or higher, you need to tell your physician or get to the ER because you need antibiotics now because you don't have immune systems, basically. Sickle cell children are told the same thing. And this is what happens. Many of them start with this little fever, and they don't come right away. And now fever's burning more of their body's, fluid, and now getting more dehydrated. And now the cells are getting stuck more. And now the pain. The fever's due to the infection. Now, sometimes physical, emotional stress. And most of all, sickle cell crisis is all about the dehydration and not being considerate of, all right, you don't think about this with sickle cell, but what if you go up in an airplane and you're in the compressed cabin and your sickle cell, it's squeezing the blood vessels, making them small, right? So a sickle cell patient, child, adult, should hydrate a lot before going up in an airplane. I mean, think about it. Keep the cells. What else? What about people with sickle cell disease who live where it's cold? Well, it's to keep yourself warm, not to go out in the cold without being covered, because that vessel constriction from cold is going to create sickle cell problems. So, sickle cell. So what do we do? Well, that child comes in complaining that left knee, it hurts. And you can see it's red, it's swollen. Number one, they are already most likely with an extremely low hemoglobin hematocrit. Usually, children that come in this bad crisis, um, usually have already gotten their hemoglobin hematocrit low. If I see a hemoglobin of 7, I was happy. They usually come in with 5 or 6 and immediately need blood down in the emergency room because they're extremely depleted. Okay. So, number one, rest, stop them from burning any energy. And then, priority, give them fluid. Now, these children hurt. I mean, they're crying. So, in the other hand, is my pain medicine, but I want to treat the reason, the cause of that sickle cell crisis is tiny vessels. Let's dilate them. And then I know you're in pain. So I've treated it. Now I'm seeing what's caused by it. All right, let me give you something to help you with that. So it's one of those. Now, also, what you can do to make those vessels get more dilated is heat. Hot packs, hospitals always have them wherever it hurts. A lot of times, they come in, their electrolytes aren't good. Remember, dehydration is part of them, so we got to look for that. As I said many times, I would say 8 out of 10 times, a child with sickle cell crisis coming in is going to get blood started down in the emergency room. And also, because most of them with children, it's because of infection, they're going to be starting IV antibiotics first. That's priority to start on these children. Now, children, they're just building immune systems, right? So from 2 months till about 5 years old, which is all that time where everybody swapping spit in daycare and all the germs, right? And building their big immune systems. So by age 5, they've built that already. Well, these children are taking prophylactic antibiotics to help them because they can't fight it like other children do. But then at 5 years, they don't anymore. So from there on, they're, more apt to get infections. So antibiotics for infections, they'll be given. I mean, they try to help when they're younger, but once they get older, that's what you will see. Of course, with sickle cell, you're always going to monitor the retic count, and of course, blood transfusions. I've already said that because red blood cells gives oxygen and it gives iron to the body, and it's what the body needs, of course. Now, there is no cure. Um, I've seen some children get bone marrow transplant. Did it work or not? It wasn't to be seen yet, so I don't really have an answer, but I've seen it done. The biggest thing with sickling episodes is to prevent them. Treat the kid normally. But if they're going to go play sports, hydrate them before, during, after, all the time. Have them aware, cold, dressing in airplanes, or even going up, 2 miles, high on a mountain or something that might have something. I don't know. Hydrate, hydrate. And of course, be very aware of their bodies, with infection, of course, immunizations, preventing things, but getting medical care quick. And that does help them live long, good lives, but it has to be aware. You have to be aware. So again, our goal, early intervention. Let's prevent any big problems. The penicillin for the young kids, it's once a day. It's not twice a day. It's once a day, prophylactic. Another thing I did mention, it could be in the head and it could be in the chest. Remember, it could be a stroke or sickle. We don't know, so be very careful. It could be a stroke that happens up there. Remember, it could mimic things like pulmonary embolus. So, and it could be pulmonary embolus. So be aware of those things. Again, try to treat the kid normally. And again, our goal is that preventing. Now, thalassemia. We've got the shapes of the sickle, African American sickle cell anemia. Now we have rectangular shaped cells, and this is the red blood cells from thalassemia, which from the Mediterranean Sea. Now, what happens like sickle cell? These have very shortened lives. That's why the hemoglobin hematocrit is low on sickle cell. Thalassemia, they produce cells like that don't work right, and they explode quickly, very quickly. Now, the problem with red blood cells, what's inside of them? Oxygen and iron, right? So when these red blood cells are exploding, they're losing oxygen, so fatigue, whatnot. But the iron in the cell becomes a problem, and children, adults become toxic with it. So it's a twofold thing. Now, there are 4 types of thalassemia, but when you're tested on, when you look at it, only remember thalassemia major, which is Cooley's anemia. That's when you need to be on transfusion to survive. So I just told you, the body's making these blood cells, but they're not working and they're exploding all the time. And then you have all this iron in the body and it's toxic to the body. So they get transfusions for the red blood cells to live. Now, many of them do splenectomies. Let's get rid of the source of the production of the red blood cells. That's one of the things that they do. Now, we figure out somebody has thalassemia. Well, at birth, you don't see it. You know, at birth, you may or may not see sickle cell. or you may know just to go look for it. But with thalassemia, at birth, they're normal cells. And then somewhere about 6 weeks, the cells change to those rectangular sort of changes. And then what you're going to see is severe anemia and growth failure. Now, why would you look for a red blood cell count or a CBC? Well, that child is anemic. The brain's not getting food. You can see this cognition, they're not going to be developmentally where they should be. And that's when you go looking for this sort of things. You'll just take a CBC and find it just because it was in the CBC. So that's how they would go looking for it. Now, as I said, these children, if they go to the point of being that Cooley's anemia, which is the fourth, the worst of all of them, they're going to be needing blood transfusions to live. Now, they still have the spleen in there, and the body is still producing its own rectangular shaped cells. They're going to keep exploding, and the body's going to have toxic iron in there to cause seizure, death, and mental changes, etc. So they give something called iron chelating drugs called desferal, and it combines with the iron and they excrete it. Now, many times that's not enough. And there's something that they called apheresis. And if you looked at it, it looks almost like a dialysis like type machine, but it doesn't clean the whole blood. What it does, it pulls a component out, whether you want to just take out platelets, you just want to take out iron. You can, I don't know how it's done, but it's programmed, and that's what it does. And again, it's another thing this child has to do is to get this blood clean and get all of these blood transfusions. Can you imagine? So the big thing is compliance, of course. And then this child is constantly in therapies, constantly getting blood. Something's going on, right? And then if I had to have blood transfusions, and I really don't know how frequently they get them. I don't know that answer. But even if it was once every 2 weeks, once a month, can you imagine? That's 12 to 20 every year. What if all of a sudden you're getting all of these different weird antigens in your blood? Now you don't have a blood type or blood that you can take. Can you imagine blood transfusion reactions? So that's what I would be concerned. Now, many of these people do live okay, but it's a lot of dedication and compliance most of the time. Because remember, if we are getting blood transfusions all the time, that means our hemoglobin goes way down and the heart beats really fast. And then you give me blood, and my heart says, okay. And then you lose your blood, and then my heart beats really fast. And then you give it, and you're okay. That up and down causes heart failure. The heart gives up. Then the other thing is post-splenectomy sepsis. There's no immune system. It's an autoimmune disease again. And also multi-organ also goes with it. Now, bone transplant, thalassemia, sickle cell, it might. They're not really sure yet, but it's potential. Now, aplastic anemia. When we talk about, again, this aplastic anemia, it's pancocytopenia. It's the top one that we talk about. It's talking about white blood cells, red blood cells, and platelets. It's talking about infection, your hemoglobin, and it's talking about bleeding. All three things is a suppression of all of those things. So, profound anemia, leukopenia, no white blood cells, thrombocytopenia, no platelets, you're bleeding somewhere. So, this is a condition. What they do with this one, because it's so, it's everything that it's affecting they treat it almost like leukemia with chemotherapy and bone marrow transplant. Does it work? Well, sometimes bone marrow does, don't, but that's the way they treat it. Now, hemostasis, bleeding. You think about a hereditary thing, bleeding, you think of hemophilia. Hemophilia, 80% comes from X-linked recessive. So it comes from mommy to the child. There are different sort of hemophilias, and all that says is there's certain things in your blood. You need everything for your blood to clot normally. With hemophilia, one of the big components missing. Well, in what everybody thinks hemophilia is factor 8. Now, there are different factors. They have factor 8, but they don't have factor 9. And then you have another one where instead of saying factor 10, there was somebody called von Willebrand who found a factor and named it after himself. So it's that factor and factor 8. I've actually seen more von Willebrands than I have of the other ones, believe it or not. Because I'm like, von Willebrand, I was like, I don't understand. And I actually had to go look it up. Now, how do we get this figure out about hemophilia? Well, this might be the one who's bruising. This might be the one that you're seeing is bleeding and it doesn't stop. This might be the one epistaxis. I mean, that's usually the platelet ones that's coming next, but it could be here. Now, as I said, it comes from mommy. Sometimes the bruising, we might see a bruise like ecchymotic outside a arm, a leg, or somewhere. But remember, it could go really deep and it could still be oozing, bleeding. Remember, they don't clot, they're still bleeding. Also, the biggest one to be concerned about is going like inside a knee joint, and that capsule's getting all that blood, and that joint capsule's going to die because it's irritating to them if it's constantly irritated. So hemarthrosis is a big one that family needs to know what to do with it. And I'll go in it in a second. Now, you get a child in complaining of, let's say it's the knee and it's swollen, and you see, little bruises, you do lab work. You want to do the whole bleeding panel because you're having a suspicion here. Now, many of them are send out. You're not going to see them for a week. And, I worked in the emergency room. I want to know now what's going on. So, the way that you figure out the probability that this is going to be hemophilia is when you start seeing a normal platelet count. Platelet count's normal, but your PTT, that's how you measure heparin, is way prolonged. And you're like, okay, so now I know as a nurse, given report upstairs, put them on bleeding precautions because it's probably hemophilia. Now, how do we treat a child that comes in with that knee who's full of, blood and um, what are we going to do? Well, at home, you can have home therapy going on. Um, I tell my classes about this father and this son. He was 8, 9 years old, something like that. And they didn't know if they should give the factor for whatever reason. They came into the ER and our doctor said, yeah, go ahead, give it. And the father wanted to do it himself. And I'm like, I said, can I watch? And then of course, what it was really neat, I had a brand new nurse that I was orienting in. So we stood to the side and we said nothing. And we watched this father prepare it was put it in a big syringe. It was like about 10, 15 mLs that he had to put in the tubing. He had to start a butterfly and slowly infuse it, okay, with his son who was 9 years old. Well, this man gave my student person that day, my new person, a lesson on unbelievable technique. He washed his hands. The son picked out the site. They cleaned it right. He did the medicine right. I mean, he was explaining to my new person what he was doing, why he was doing it. And I'm just sitting there going, you know, kudos. I couldn't have done any better. And I am extremely OCD. So it's a memory that I remember. It can be done so well at home. Now, that's if you have to be IV. There is up the nose, some of it, and there's something called desmopressin. Now, desmopressin is going to be also in next week's lecture. It's also used for diabetes insipidus, which is you urinate a lot, you drink a lot, and we'll go into that one. But it's also used for hemophilia. And then there's other stuff here. Now, care management, very important. You've just got this new toddler home, found out that they're hemophilia. Now you got to protect them from their own environment, right? I remember, was it a couple Hessies ago, they were talking about toddler safety hemophilia. And I went, wow, all right, had to put this into the lecture. Think about the coffee table. Think about underneath, things sticking out, anything pointing is like protect the environment. That's number one, which means it prevents, injury. But something happens, immediately sit them down. Number one, calm them down. Remember, heart rate, calm it down. You're not going to bleed as much, right? And then everything to constrict it that you can think of, which is elevate it up, put ice on it, and then an ace bandage and hold it there. Now, if it's one of those ones that need home environment, they know how to do it. That's going to be, at that point, the parents have been taught either to call the doctor or just to go ahead. So it's rice, which you're going to see in orthopedics, when we talk about bones and whatnot, but it's also here with hemophilia. Prognosis is not bad. Again, it's protecting. It's like a kid with hemophilia, you're not going to have them play tackle football. I mean, they're going to be, you have to be thoughtful about, being as normal as you can be. But of course, being safe with the child. They are working on gene copies. It's not quite there, but I can see this something soon. Now, remember I said there's something with platelets if it's low, and um, I really think it's going to be immune thrombocytopenia, and the last part is purpura. So, immune thrombocytopenia purpura, ITP, P is platelets. Platelets are extremely low, and they usually follow some sort of upper respiratory viral something within the last month. And all of a sudden, this is the child that comes in the epistaxis. This is the third time this week. They've already been to the doctor twice. They're tired. Coming to the ER. Now, we tend to put them in a gown and look at the body. It's like this, let's say 5, 6-year-old child. They're take things off and you see this little tiny little purple, like that looking rash, like that hand there, like on their legs, or maybe on their somewhere. And the parent almost like, oh my goodness, but this kid doesn't go out to play at all. I don't know why. That's not because he's fallen down. Clues going on here, right? So, yes, he's been sick. Now we're seeing these things. So, how do we diagnose this? The CBC. Again, CBC. Now, because, we're looking, white cells, normal, hemoglobin hematocrit, they're normal. Platelets, ugh, they're 18,000. They should be 100,000 at the lowest. So the assessment goes back. They figure out, yes, he was sick. So yes, he has acute ITP. Now, sometimes for whatever reason, I don't know if it's compliance or how quick they got care, I'm not sure. But if they say the treatment takes more than 1 year, they call it chronic. But most of them we treat with get them in the hospital, give them some intravenous immunoglobulins, give them some anti D. A lot of times these will get steroids. So put that one on the list. It says sometimes, put it on the list. And then they're admitted. Now, these children don't have platelets. They're going to bleed. So these children are on bleeding precautions. What is that? Well, number one, you're going to teach that child. I mean, if it's an adolescent, you're going to say you can't shave, right? Nothing sharp, or look at toothbrushes, make sure they're soft. I mean, telling them if you see any blood in the urine and the stool, let me know, or if you see any bruising, right? Teaching. And then we're not going to put any venipunctures in this child. We want to use existing IVs or what we have. And then, of course, we're looking physically too. Nosebleeds, below the nose. All right, there's no blood in there. The mouth looks okay. Ask the child or check the bathroom out, what goes on there, right? Being sure. And then, of course, as we're doing the CBC in the morning to see if our treatment's working, let's look at the platelet counts. Are they coming? Can I see a difference in them? And as I said, just put steroids on the list. They're done. Now, as I said, epistaxis, and this is what I said, we'll get those. Sometimes it's even leukemia. We find out, but most of the time I have seen in my it's ITP. What I've seen most of it come out to be, but it's going to be an NCLEX question. What do you do with a nosebleed? Number one, they're bleeding. Calm them down. Decrease their heart rate. Okay, bleeding will slow down. Put them on mom's lap, your lap, wherever they want to be, and lean them forward. Take your thumb and forefinger, put it on the bridge of the nose. We put them forward because if you put them back, they're going to be just swallowing blood and then they're going to vomit blood everywhere. And you don't want that. You put them forward, if they're bleeding that much, it'll come out their mouth. And then all right, at this point, to the ER. Now, after 10 minutes, kid's still there, leaning forward. You take off your fingers and they're still bleeding. You need medical attention now. Sometimes it's EOR, sometimes it's nasal tampons. I can't tell you, it's all different things in the end. So, the epistaxis, it does help us look at many different things because is it that platelet count down, right? So, think about it. Now, HIV, AIDS, immune stuff. When we're talking HIV, AIDS, we're talking about how it gets to the pediatric population. So, mommy can give it, right? So, during pregnancy, there is a therapy. There's highly active antiretroviral therapy, heart therapy, and we can start that with mom at 22 weeks pregnancy and then continue after birth. Now, why do we give an antiretroviral therapy? There's no cure, right? Well, what we want to do for this infant is to boost their immune system as well as they can. Okay, biggest goal with immune things like this is to see what more can we do to help that infant, that newborn fight it. Now, there are so many new things that are developed all the time. Now, let me tell you one experience that I could tell you stories, but this one I think def explains HIV, AIDS, and getting treatment for the children and the possibilities are possible. This one woman, and I met these three girls, triplets, in a site that I was doing the pediatric clinicals. One of the little girls had AIDS. One of the little girls had HIV. The third had nothing. So, why was the third girl without? Well, there are three different ones, but they all had the same chance. But it's just showing you that there is a possibility, isn't there? And that's what I'm talking about. I've also heard in my career working in the newborn ICU that some HIV babies do auto convert, and then at a year old, they are no longer. So I've heard these things, but I've seen an example of it. So one of the biggest infections that do cause children HIV to die is pneumocystic pneumonia, PCP pneumonia. You know, me and you is a virus. It's not going to hurt us this way, but children with HIV, it is extremely dangerous. Okay. So again, everything we do for these children is to boost an immune system. So we're going to give blood, right? All types of blood. We got platelets, we got FFP, we got albumin, we can give 5%, 25%, pack cells, red blood cells. There's so many different things that we can give. The thing that our responsibility is always follow hospital policy, because if anything's going to go wrong, it's going to be some sort of reaction to red blood cells, and you could look at the documentation that you did it right, okay? Because reactions do occur more frequently than an antibiotic usually. So always follow policy. So take the vital sign, check it with another nurse, hang it up, come back in 15 minutes, do another set of vital signs, and then every hour for 4 hours. That was the policy, that I followed. And usually, if there's going to be a reaction, it's that first 15 minutes. So I would always leave whoever I could, a nursing assistant, somebody with the patient if I had to keep moving. Okay. Always an infusion pump, unless you're in the ER and that's trauma, something different. But on the floors, in the unit, infusion pumps, you can monitor it regularly going in. I mentioned apheresis when I talked about iron, and we could take it out, right, in thalassemia. And then, as I said, you can also take out platelets. If, I wanted to give it to my son, my daughter, here, take my platelets, right? Now, one of the things we do for these disorders, once we find out they're, hemophiliac or they're this or they're that, um, do a bone marrow aspiration. We want to see what's going on. So one of the things is preparing children. Now, I don't know if any of you have ever had the opportunity to look at a bone marrow aspiration or hear what it sounds like. Well, most of them are put, pretty well to sleep, sedation. But when they put that big blue needle down, like into the iliac crest, you'll hear, and then you'll feel the give. And then they're into the marrow area. But the sound, I still can't get over it. It's one of those. But please tell these children won't remember. But again, it does hurt no matter how good, they're giving all of that numbing. Just tell them, here, be honest. It's going to hurt a little. So when both parents have a sickle cell trait, what's the chance that each of their children is going to have it?
25.
Wouldn't that be a 50 out of 50 chance?
If both had the trait, to have the disease is 25%. The disease. Okay, children with cancer, all sorts of cancer we're going to cover here. So let's start with leukemia and lymphomas. Leukemias attacks the blood, right? It attacks the immune system. It attacks the white blood cells, and it produces white blood cells that just don't work. So the body cannot fight infection at all. It actually is the most common form of childhood cancer. And it's hard to watch these young kids, come in like what I did, worked in the emergency room, come in with a temperature, needed me to, get to their port and draw labs and all do all the things you had to do. And then you got to know the parents and the brothers and the sisters. But, oh, Betty's here. What can she take care of them for me? And then it's all right, no problem. You feel like, all right, I've got a confidence there. So it's hard, but it's actually very rewarding. More common in boys that are older than one. And look at poor Down's children. They are now at higher risk for leukemia. They're at higher risk for congenital heart disease, leukemia. Oh, hypothyroidism's coming next. Let's see what else for children. So the big definition is the unrestricted proliferation of immature white blood cells in the blood forming tissues. So white blood cells are coming out, but they don't do anything. Remember, their lean, their liver and their spleen, are producing these things and they get really affected with what's going on. Now, how do we diagnose leukemia? Well, it's going to be based on what the patient says. And I'm going to tell you about my neighbor that I grew up with, this young girl. And as a young teenager, he went to the ER. She was, I don't know, 14, 13, that area. And she was complaining of flu-like fever. Oh, not feeling good. No energy. Her knee was killing her, and she had these bruising and didn't understand. And she went into the ER. They saw the bruising, the pain, the this, the that. They did a CBC, and this young girl, classic signs and symptoms of leukemia. So it's one of those things that, you know, the signs are, is it flu? Right? I might have thought maybe it's a flu, but no, the parents brought her in. Anyway, so what they do when they figure it out, they're going to do a lumbar puncture. Let's see if there's anything in there that's involved. Bone marrows, looking to see, how's the body functioning. And remember, a lot of these things don't feel good. Again, I said it, I say it again, be honest, let them know. Now, you figure out, you've done everything, and now you're starting all the chemotherapy. Now, the first 4 to 6 weeks is intense. It might be 3 different chemos, once a week, twice a week, I don't know, depending on the physician. They're not feel good experiences, and these children are pretty wiped out from them. With remember, this chemo is not only killing white blood cells that are cancerous, they're also getting the other red blood cells. They're becoming anemic and they're weak and their immune systems are very low. And that first 4 to 6 weeks, hopefully, they have achieved remission when they come out the other side. And you're going to say 4 to 6 weeks remission? Yes, but cancer can be sneaky. So they do more therapy, and it's all that to be sure there's nothing hiding. They do the central nervous system, the intrathecal, and then they actually do another therapy just to be sure, and then a maintenance, which is usually a pill today. So remember, 4 phases. The first one, induction, 4 to 6 weeks. They're hit with everything. Goal is remission. Now, sometimes nothing's working. They've tried. Chemo's not working, and or it worked, and now they're back, and it's not working anymore, and now they have to think about hematopoietic stem cell transplant. Now, today, many new parents are faced with, do you want to save the baby's cord blood? And it costs a lot of money. And many parents say, I wish I could. I can. I don't know anybody in my family that, so you don't do it. Well, the best of all of the things is, and if you're older, if you had saved it somewhere for whatever reason, um, that is what we call an autologous stem cell transplant. If it's mine, okay, it comes from me. Automatically, mine is the best. That's how we remember autologous. Now, I didn't, and I don't have any. So I still need a stem cell transplant person. I need somebody. Well, it doesn't matter blood type here, which is interesting. I mean, in blood, it does negative, positive, O, A, B, right? No, this one doesn't matter. What they're saying with all the others, allogenic, all the others, the best choices probably are their siblings, their brothers, their sisters, probably. So, second choice. Beyond that, is it mother or father? Remember, usually siblings are mother and father. So it's the same sort of thing. But remember, in this, automatically mine is autologous transplant, and allogenic, all the others is, the brothers or sisters and everybody else. Again, with leukemia, it's constantly coming in, getting port accessed, missing school, not feeling good, vomiting, just feeling miserable a lot. Sometimes there's oral blisters, anal blisters. There's so many things that can go on. Again, prepare the parents, and not so vividly explain to the child what they might be feeling and say, if your mouth hurts, we got some really good popsicles, change it around. So, like I said, now in leukemia, as a nurse, you need to work with chemotherapeutic agents. There's a certification for it now. And if you look at nursing with a year experience that are certified, they're paying big sign-on bonuses around the country, like 20, $25,000. It's, yes, you're working with leukemia, cancer, but I've always said, not all of my children lived, but some did. And it's what I gave all of them all the time and made them smile. That's what I'll remember. Okay. It's not the sadness. So, leukemia, how do you say who's going to make it? Well, what was the white count? So, my friend, my children's, friend that they grew up with, was 0.1. I've seen them 0.01, and they didn't do as well. How old were they? Younger, older? Boy, girl makes a difference. Was it ALL or AML? AML is a harder leukemia to cure than the most common, which is the acute lymphocytic leukemia, the ALL. Also, remember, their blood is being destroyed and they're getting transfusions. Remember, the karyotype, the blood type, makes a difference. If they have one of those rare things, it could be a delay in getting what they need. Remember, there's all sorts of things. We have radiation, chemo, surgery, all sorts of things that we do for these children. You know, understanding what they're going through. I explained it to you, just explaining signs, from the friend that we grew up with, pain, fever, ecchymosis, bleeding. Well, she didn't have bleeding, but lethargy, weight loss, general loss, all of these things, the headaches, exactly what she was feeling to understand it. Now, this is a slide that's put in the middle of chemo and immunosuppressed patients. I want you to know that neutrophil counts are something that should be looked at. If you have, a CBC, you're going to have a neutrophil count. Usually 2000 is a good number. Now, neutrophils are your immune system. So if you have any age, child, adult, with a neutrophil count less than 500, and then you get report that child, that adult has a fever, that person, child, is about to go into shock. There is no immune system, and they're already starting a fever. That's your priority patient. So that's how I just showed you how to prioritize a patient. Acuteness of illness. So remember, neutrophil counts less than 500, any type of patient with a fever, trouble. They have leukemia. Oh my God, that one's in trouble. But doesn't always have to be that as a leukemia. So with chemotherapy, hemorrhages can happen. Remember, this child's going to get a lot of all different sort of blood transfusions during therapy, because their platelets, everything is down. Don't have them in things that are going to have them, bumping and bruising. I always say a swimming pool is always heaven sent. When you have somebody who needs to get energy. But see, I like the water. I'd be right next to them. But they're how am I going to hurt myself in there? And then of course, remember, hemoglobin hematocrit's going to be constantly going down. Limit activities. Don't overtire them. They're going to be ill. They're going to feel nauseous. Getting medications before and then continuing it, being on time, monitoring nutrition. They said they get blisters in their mouth. So high protein, high calorie, full fat, littlest amounts of the highest everything you could give them. That's what you want to do. And then if it's, going on for a while, your weights are going to tell you, are they maintaining or are they losing weight? They're losing weight. You need more nutrition. I told you the mouth will be like that. Again, foods and making sure nothing in there is going to burn or sting. Remember, with low bleeding things, you always are concerned about. These children are getting narcotics. They're in pain. They're going to be constipated, right? They're not eating. They're going to be pushing to have a stool. They could have a stroke. Their blood is thin. Okay? Be aware of those types of things. They also could have bleeding from anywhere. And then, of course, we always say, you think chemotherapy, first thing you say, oh, they're going to lose their hair. And of course, some of them get steroids. And then, can you imagine having this big puffy face? Depending on the age of the child, it might make a big difference, right? Just be aware of that visual. Again, preparing children, making sure that we're doing everything possible to make it as least painful. So, topical and deep infiltration is what we want, knowing that pain management should be regular, and it's just pain. It's hot, it's cold, it's music, it's TV, it's so many things. And then, don't say, well, they haven't cried. Well, give it to them before they cry, right? We know children that are with these immune systems like leukemia. You got to be careful. They still need regular checkups and whatnot. You just have to be aware when they're sick, they don't go nowhere. They do not get live attenuated viruses. It's contraindicated. You have that inactivated ones that they can get. Now, the family, you gotta be careful. Some they can get, some they cannot. And then the big thing we don't think of, varicella is extremely dangerous and will kill these children if they get it. They need to have the immune globulin. They can't have the regular one, the live one, to protect them. Okay, I'm going to tell you one question on the exam, and I know 50% are going to get it wrong. And I please, 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 can you please be the first class that are more than 50%? So, lymphomas, Hodgkin's lymphomas, non Hodgkin's. You don't need to know the ages. I'm going to explain both type of lymphomas and the differences, and you need to know them. So, it's the lymph glands. In Hodgkin's lymphoma, it starts from the shoulders up. Those are usually those big neck balls and glands that are sticking out that comes to here. It can, if it goes too far, metastasize almost anywhere. But can you see how big that is? Think of Hodgkin's, that's a Hodge, a lodge, a house. I can touch it, I can feel it, I can squishy it. Okay, Hodge, it's solid, painless. I have a house, it's above my shoulders, supraclavicular. Sometimes it gets so big, it swells into the trachea and could cause coughing of GI stuff, etc., etc. The way that they do the diagnosis here is they do a biopsy. It's easy. There it is. There's my house and my Hodge, my lodge. Well, let me get a biopsy, right? Now, once they look at it, it's Sternberg Reed cells. So you're going to do some radiation to shrink that lymph node. We're going to do chemo, sometimes one, both. They're all different. And these do really, really well. All right. Now, the biggest thing with Hodgkin's disease is that risk for infertility because they're radiated, they're chemoed, because it's in the lymph system. Okay. So remember, painless, firm, I can feel it, lump, Hodge. Non Hodgkin's lymphoma. Now, it's more frequently in children. That's why it's here. But this is all over the place, diffuse. I don't see it. It's not just above my shoulders, it's diffuse. And you have to find it. It's not like, oh, I see the neck there. It's everywhere. Again, we'll get a biopsy if we can, and we'll do all of the chemo and all of that whatnot, and to get rid of it. So, Hodge, painless, firm, I can feel it. And then I have non Hodgkin's, it's not a house, I can't feel it, diffuse, all over the place, lymph nodes. Okay, nervous system. It's really hard when, you have a child and they tell you they have a brain tumor. Some of the things that these children come in with, I mean, it could just be they're in with a headache that's getting worse, or it could be vomiting, not related to eating at all. And then it also might be like they just want to, trip. a little bit, a little jittery, and you're like, something's not right here. It could go up to hydrocephalus, nystagmus, pressures out on the eyes now. It could be, dysarthria, or then it gets into the pituitary gland. Then you have diabetes insipidus. That's your posterior to pituitary, and then growth. That's your anterior. Oh my God, everything has been squished on, but that's longer term. What I told you, it's what we see initially. So, how do we diagnose? Well, always it's going to be the clinical signs. And then the most definitive of all is going to be the MRI. Yeah, they'll do a CAT scan first, and they'll go, oh, okay. And then they'll do the MRI to get specifics and whatnot. They don't do lumbar punctures on this. That extra thing that's pushing is creating pressure. And if you take something out, it could like make the brain move and shift and not do nice things. So we don't do lumbar punctures. Now, found out you got a brain tumor. We've done all the pre-testing. This is what a child will look. I mean, initially it's wrapped up, pretty big, but within a couple days, they have it off to air. And it could be incisions that look like that. Usually with brain tumors, they'll do radiation therapy, chemotherapy, shrink it up, and then do surgery. Now, the thing with brain tumors, nursing care can be really, really tricky. Now, how do you turn them? Can you turn them? Can you suction them? Can they cough? Right? Can I turn them on the good side or the surgery side? And then what about lifting the head of the bed? I mean, all of that is very clearly delineated in orders. Also, what about fluid volume? Do you want to give too much fluid to that child? It'll go right to the head and cause swelling, right? So we don't want to do that. Again, it's all about comfort, keeping the kid quiet, making them comfortable, right? Having the parents there. Many of them, some of them come out fine. Some of them are going to need therapies to catch up. But anyway, um, they're scary, even for nurses to see that going on post-op. Now, there's something called a neuroblastoma. I'm mentioning it briefly. It is a big tumor in the abdomen that actually grows very large, and it can grow like that abdomen. This is the extreme, okay? Usually, what happens with this one and why we mention it is when we finally figure out what's going on with that child, it is already gone into the brain and metastasized. And sometimes it goes to the point in the brain where now the eyes are pushing out, and you have that exophthalmos and swelling and bruising and stuff going on. It doesn't happen a lot, but abdomen mass, neuroblastoma, think it's already metastasized. And that's what that's about. Now, bone tumors. Bone tumors are hard sometimes to diagnose. When we talk about bone tumors in this chapter, we're talking about cancer in the femur. And it is usually at first this patient will all of a sudden, go, oh, and my knee hurts, and just maybe put some, Tiger Balm on it or something, maybe take a towel, and it continues to get worse, and it gets worse. And then it gets to the point now they're limping. Now it's starting to impede upon them and hurt. And now mom goes, what's wrong with you? Oh, my knee hurts. So they take them in, they do an x-ray, and they find this fuzz on it, and they say, you have cancer of the femur bone. You have an osteosarcoma. The problem with osteosarcoma is the bone completely is infected with cancer. The whole femur bone has to come out, and then they could be cured. So we had the kid, gave me all those signs and symptoms, what was going on. I mean, along with it, he might look anemic, weight loss, might have had infections. How long this has been there. But again, usually it's just that simple x-ray, and then they go further in, CAT scan, MRI, and maybe do a biopsy, and then we go to surgery. Now, surgery is big. They take the whole leg off from the hip. That whole femur bone that's in that hip bone is taken away. And they take the lower leg somehow, they turn it around and put it up in the hip bone. So the foot goes backwards and it becomes an area where a prosthesis can be placed on. So these children becoming adults can be ambulatory. Can you imagine? So the goal of osteosarcoma surgery is to salvage the limb. Can you imagine this adolescent? Can you imagine therapies? Yes. Wilms tumor. Wilms tumor is usually young little boys, and I've seen only one of these in my career. And I was in the triage area, and my hospital had just come back from a trip to Haiti after an earthquake down there a couple of years back. And a religious group got him here. So these people brought him in my triage room, and I'm like, okay, so why is he here? They go, I don't know. Here's the medical records. And I look at the medical records, and they're all in French. I'm like, okay, now I've got to use my assessment skills. Well, first, I have a 3-year-old child just flown over from another country who's brought to a hospital who's scared to death. So I did what I had to do, and I got his vitals done. I had him smiling, and I had him to high five me by the time he left the room. Now, as I did his assessment, and I had to know where to place him. So I had to listen to the lungs good. I had to take good vital signs, listen to the heart. And then when I felt the abdomen, that left lower quadrant had a softball, hard cyst in there. And for some reason, I knew it was Wilms tumor. So immediately I put a sign there. The problem with Wilms tumor, nursing care, those tumors are extremely fragile. They should never be unnecessarily manipulated for any reason because pieces break off and it will metastasize. Now, post operatively, this kid did great and went back to Haiti. Okay, but big thing, what we do is radiation, we do chemo, one or the other or both. Do surgery. Remember, surgery for kidneys is through all of the intestines, all the way back to those kidneys. So, operatively, and they get that tumor out. This child is going to have a problem maybe with their bowels. They might go, you know, not have an obstruction because they're not moving. And then remember, it was the kidneys that it was attached to. So the urine too, you got to be careful with that also. So those are some things with tumor. Retinoblastoma. Have you ever gone outside in the dark with a light on and see your cat or dog and see these eyes that are white, shiny? We call them cat's eyes. For animals, it's normal, but for humans, it's not. And when you see a cat's eye like this, it is retinoblastoma, an extremely aggressive cancer of the retina in the eye. They do radiation. Remember those purple spots? Never, ever, ever wipe them off because the next radiation will put the ray in the same place. When you're talking to these families about, you just found out they have, this cancer. Um, has there been any other problems with their eyes? Have they had infections or, you know, do they see out of it or do they rub it or, is there anything that would have drawn attention to it earlier, right? And then post-operatively, they take the eye out. And when they're old enough, they will put a false one in there. Another thing we don't think about with cancer, testicular cancer. Now, women do a breast exam, hopefully once a month, right? Well, men should do testicular exams. I had an 18-year-old boy come into the triage complaining of testicular pain. And I was in the room with another nurse. And she said, okay, drop your drawers. And she put a glove on and see where is the pain. And one of the testicles was, again, huge, size of a melon. And she goes, oh boy, but you can't show that. So we dressed him up and we sent him back to the room. Found out he went, did an ultrasound. It was huge, but the doctor also asked for a chest and an abdominal x-ray. He had already metastasized everywhere with testicular cancer at age 18. Liver cancer, had a low bout, it'll grow back. I mean, the liver is a pretty cool organ. You know, more and more and more and more children survive. So much is going on there. Know that, keeping up with it is hard and all of the changes of it. But, if you ever work in the cancer area, I think the positive attitude, I know I love cardiac. And I know that when I got into it in the 80s, up to when I left it, night and day. And it's such pleasant to watch those things. So that's what you wish, don't you? Cancer free. Yes, for me. Any questions? We're a little bit early. Is there anything you need me to go over with you at all? We go to 10 o'clock, we're good. If you want me to start the cahoots, I will. What do you want me to do? Okay, here we go. Let's get going. It's a good cahoot, actually. Oh, I like all my cahoots. What is priority treatment for a newborn of an HIV positive mother? What is your goal? What's the treatment plan? Remember, our whole focus when the baby is born is the baby, and the baby came from a mother with a depleted immune system. So let's get those antivirals in. Let's boost that immune system. Let's give the baby a chance. What are symptoms of sickle cell anemia? Remember, he said those cells get clogged up somewhere, vessels aren't big enough, and then the blood backs up behind it and it swells and it's miserable. And it's all about swelling pain. It can be in the eyes, remember. Remember, it can be in the brain. Is it a stroke or is it in the brain, right? It could be in the chest or is it a pulmonary embolus? So, where is it? It could be many things. What kind of hematocrit would someone with sickle cell have and why? Remember, I said just like sickle cell thalassemia, what's the one thing about their red blood cells? Remember, every time somebody came in a sickle cell crisis, 8 out of 10, I'm going to give blood. And the reason? It's because their hemoglobin hematocrit are low because their cells are dying faster. Okay? Very, very important concept there. You're going to see it in med-surg too. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? What do you need to do? Number one. So, do you want to treat a symptom or do you want to treat the cause? That is the answer to the question. So, I don't want to treat a symptom, it's the pain. What caused the pain? Let's get the IV in, start the bolus, dilate the vessel, as the other hand is administering morphine, hydromorphone, whatever it is for the pain. Priority is to take care of why. What is the reason children with iron deficient anemia are easily tired? Iron deficient anemia, any anemia, not enough red blood cells. I don't have oxygen. I don't have iron. Gee, don't have enough red blood cells to carry the food and the nutrients I need. I'm going to be tired. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? So, on an empty stomach, orange juice is your best bet. You're going to do it through a straw so you don't stain the teeth. The stool is going to turn this tarry, gooey black. That would scare me if I didn't know about that. Never ever with milk because you don't want to coat the stomach. So, one thing about iron, it needs acid to break it down to be able to be used by the body. So orange juice, empty, gastric acid, poof, it works. So, and never after meals, before. Aplastic anemia includes a depression of which cells? I think of all the anemias, this one. I think there's nothing that it doesn't attack, isn't it? It's going to attack my immune system. It's going to attack my energy, my red blood cells, and it's going to attack bleeding. So, this is the one that you treat like it's leukemia. So, it's a really long term care for it. Most common type of anemia. Iron deficiency. Good job. What causes pernicious anemia? I love that word, promiscuous. Say it 3 times fast, right? Anyway, that's the intrinsic factor. That's the stomach. It's a B12 deficiency. Yes. How do you treat it? You give B12. What symptom is the single most common symptom of anemia? Absolutely fatigue. Good job. The fatigue is the first thing, and the rest of them, you touch them, you'll see other stuff. But yeah, what teaching, when teaching parents about beta thalassemia, the nurse informs that the child's at risk for what? Beta thalassemia. What happens with thalassemia? The square cells burst, spewing oxygen and iron in the blood. So it would always be too much iron and hypoxic. Okay. That's what thalassemia is. How do we treat it? Which is the Cooley's anemia. It's transfusions. What values will you see with hemophilia? Remember, this is what you could see right away. All of those bleeding counts, factor 8. He sent it out to labs. You're lucky if you get it a week later. But absolutely, PTT is prolonged and the PT platelets absolutely normal. You're like, okay, something's going on. They're not on heparin here. What is immune thrombocytopenia purpura? ITP. P. What is P for? Happens after an upper respiratory. ITP, P for platelets, not enough platelets, and this is that little petechial rash and maybe some epistaxis. Thrombocytopenia can cause the following symptoms. So that's ITP again. So again, ITP, P platelets, it's that ecchymosis, that's petechial hemorrhage. That's the nose is bleeding. You're like, something's going on. And that's when you do the CBC. A multi. A child with hemophilia has fallen, the knee's swollen, painful. What treatment would include what? What would you do for this child? So the child has hemophilia, has a bleeding issue. He's fallen down and his knee is swollen. It's painful. How do you treat that? So you're going to rice, right? You're going to rest, ice, contain, elevate. You're not going to exercise it and you're cold packing it because you want to constrict the vessels. Hot pack, no, that would dilate, cause bleeding. What's the priority nursing action for suspected blood transfusion reaction? So you're giving blood and all of a sudden they spike a temp of 102. Turn it off, period. Turn it off. And then take it off and let everybody know. A child is admitted with neutropenia. Which nursing action takes priority? What does neutropenia mean? Neutropenia. That means a decreased white blood cell, which means decreased immune system. Wash your hands. That's it. That's the best thing you can do. Which symptoms would a healthcare professional expect to see in a child with leukemia? Think about my neighbor. Very, very classic signs. Oh, by the way, she's a PhD in psychology today. She has a PhD from University of Miami. Very smart girl. Anyway, that bruising, petechiae, that bone pain, that terrible fever, feeling terrible. Yes. Your child with ALL has had recent lab results with a platelet count of 10,000. The nursing action. Now, does it matter any child that has a platelet count of 10,000? You're going to do the same thing. So, platelet count 10,000, priority, bleeding precautions. Yes, thank you. A multi. A child's placed on bleeding precautions for ITP. What interventions would the nurse do? I'm going to do a little bit of everything. Remember, I said corticosteroid? Yeah, we're going to do them. So, if symptomatic, they're in there, they're in the hospital with bleeding precautions. Yes, they're symptomatic. But yes, no injections. Of course, you're going to assess and monitor that CBC. A child with a Wilms tumor, which action by the nursing student causes the faculty member to intervene. What's the precaution I told you about Wilms tumor? That was that little boy from Haiti that just showed up in my triage room and his chart was all in French. I had to figure it out. It was all about don't touch that tummy. So, again, it's an education moment, but there should have been a sign somewhere. If not, I'd put 3 signs up. A child with ALL has a fever of 100.5. What should they do? Like I told you earlier, a child with ALL or any autoimmune child is always instructed with a temperature of 100.5. What am I going to do? I'm going to tell the doctor I need to start antibiotics. I'm getting medical attention. Okay, think about it. No immune system. I have a fever. So I need help. I need antibiotics before it becomes septic shock. Child is having a bone marrow aspiration. Should you tell the child? Do you see the size of the needle that's stuck in there? It's up in the iliac crest again. If you don't numb it right, so always, I mean, we're getting a lot better today than we were when I first started pediatrics. But again, it's still going to hurt a little. You can't get it all. Most common clinical manifestation of a retinoblastoma. Retino, the retina, blastoma, sir, cancer. It's that you take a light, shine it. It's this white shine. I saw it once. I think the little girl was like 8 months old. Your child has been diagnosed with a retinoblastoma. What information is important? What do you need to know? Or what's a part of the assessment? So, part of the assessment, you always want to know, you know, anything's going on with those eyeballs. Let me know about it. A goal of surgery for a child with osteosarcoma is so osteosarcoma, in what we are discussing, it's in the femur. It'd be a little piece, it'd be a whole piece. But remember, the cancer's in the femur, the whole femur gotta go. You can't just scrape it off, okay? So you take the whole femur out, and then you salvage the bottom part of the leg below the knee, and you put it up where that hip joint was. They've been doing it successfully, actually. The child is complaining about skin markings for radiation therapy. Should told what? Remember I showed you the picture, one of the slides with a little purple thing above her eye. I mean, some people with, complex about the way they look, some children, it might bother them. I don't know if younger kids would even know it's there, but leave it there because they put that mark there, they measured closely, and that's where the gun goes the next time. When destruction is used, it helps. So, distraction in children, depending on the age, it's an amazing tool to use. They forget about the pain, they're not worrying, they're listening to music, or they're giggling, or they're trying to work an iPad. It's it works. What assessment question needs to be asked to a child with possible rheumatic fever? So, rheumatic fever is one of those diseases, and in week 8, you're going to hear about another one with the kidney, acute glomerulonephritis. Both of these conditions, if you don't treat the strep throat completely, can cause a problem. Now, rheumatic fever specifically attacks the body in different ways, in the joints and the central nervous system and movements. But the heart valve, the mitral valve, if it gets damaged, it's gone forever. They're going to have to either replace it or medically treat it. Okay. But everything else will go away once treated with long-term antibiotics. Signs and symptoms of asthma. A couple of last week's question in here. I thought they were important concepts that I wanted you to revisit. Coughing, short of breath, expiratory wheezing. Remember, so expiratory. Multi. What symptoms should be reported to the healthcare provider? A child with sickle cell disease. Which one is concerning? So remember, sickle cell disease can be anywhere in the body. What we're most concerned about, if they're telling me their head is crazy, headache, or their chest, they can't breathe, these are things that immediately, I guess I should put immediately reported to healthcare, because these are like those extreme conditions that are extremely serious. Absolute contraindication for nasal tracheal suctioning include which of the following? Anything that has to do with existing already swelling, croup, epiglottitis, and surgery, leave that mouth alone. Iron dextran is given via which route? The funny thing is, as a nursing student, I was 20 years old, scared. My first injection was an iron Z-Track on a 44-year-old woman. I was scared to death, but she said I did good. But it is deep IM, lock and load, because it keeps the med in there, doesn't stain the skin, and it won't burn it. If a child was to receive their own bone marrow, this is called a what type of transfusion? Remember, I told you what's my own and what is, everybody else. So automatically mine is the best. That is mine. Allogenic is all the others. What cancer may present with painless, firm, and enlarged cervical nodes? Means above the neck. Which one is that? Yes, yes. You're gonna get 100 on it. Yes, I'm happy. I'm multi. When teaching about sickle cell disease, you would include what? What's important? A chronic teaching that prevents crises is basic. Every child, every parent should know that can help. It's all about fluids, right? Plenty of fluids, dressing warmly when it's cold. They do get to take home actually like Tylenol number threes, like little codeine. It's a little bit of something that can take an edge off so they can get to the ER. And they're told to take it early. Also, any at temperature of 100.5 or greater, absolutely get to the ER. Let's get that infection before it becomes septic. Thalassemia major is primarily treated with what? Cooley's anemia, fourth stage. And this is a picture of a girl. They have some of dysmorphic like areas like bone marrow produced, like in the cheeks, that it got bigger. It's one of the distinctive features of them. And yes, thalassemia major is all transfusions. Multi. Treatment of osteosarcoma includes osteosarcoma, bone cancer. You got to take the bone out and get it out. Treatment. I do radiation, I do chemo, I salvage or I amputate it. Stem cell transplant does nothing for a bone that has to just be taken out. So, all the others. Die. Who are the best donors for bone marrow transplant? I had to guess. Who are the best? So, me or my siblings would be the best of all of them. Mom is half of me, my siblings is better. What is the most common opportunistic infection for children with HIV? I remember when I learned about PCP pneumonia was in the 80s at a county hospital. I had a patient crash on me, and they told me it was PCP pneumonia. And I'm like, oh my goodness. They're like, no, you're not, it doesn't hurt you. It's those with HIV, AIDS that they cannot tolerate it. So PCP pneumonia, most common. What would you consider to be neutropenia or a low neutrophil count in children? And remember, our concern with neutropenia is there's no defense here. We're a weakened one. And if they have a fever, you're in trouble. That is your priority patient to go and prioritize first. Less than 500. When you're talking over like 2,000, that's the better. It should be at least. A primary characteristic of a brain tumor is so think about it. Brain tumor's in there and it grows. When a brain tumor grows, it pushes pressure. What does pressure in the head cause? So you get a headache, but it presses more, so it gets worse. And then that pressure, it's vomiting. Nothing to do with vomiting. And then the whole thing is symptoms get worse over time. Headaches get worse over time. Vomiting not related to eating. Okay. The optimum treatment for an osteosarcoma is what is the goal? What would be the optimum thing that could happen? Remember, they're moving that whole femur bone. Salvage that limb so we have something to put a prosthesis on. And last question. A child's receiving induction of chemo. What does that mean? That's the first 4 to 6 weeks. We're giving them a load of antibiotics there, remember? High intensive chemo, goal of remission. There's 3 more steps, but that's just to make sure that there's no more in there hiding. And good job, Ed. Number two, PS. And number one, we got a meek there. Meek, meek. Jess and Cindy. All right, guys. Yeah, those cahoots are good, and I'm glad you wanted to do them. Have a good evening. Make sure you send me your new what you want to do for your pediatric assessment project, okay? Or if you want me to guide you, let me know. I'll give you some what I could figure out. How's that sound? Have a great night, everybody. Thank you.
Uh,
You